Generalized and disseminated disorders of bone. Generalized bone disorders caused by metabolic disturbances. An increase or decrease in either bone deposition or bone resorption or both. Bone deposition is the osteoblastic formation of organic matrix or osteoid and calcification of the matrix to form bone. Bone resorption is the osteoclastic removal of formed bone and the release of bone minerals. 1/3 of the total amount of bone mineral may be lost before appear in radiograph. Bone densitometry can quantitate more accurately. Rickets. Generalized disease of growing bone. Failure of calcium salt to be deposited properly in organic bone matrix or osteoid. The normal deposition of calcium and phosphorus depends on absorption of each element from the intestine, their excretion in the kidneys and the intestine, their rate of movement into and out of bone. Other important factor is vitamin D and PTH. Main causes is the vitamin D deficiency, chronic renal insufficiency, and renal tubular insufficiency. Pathology of rickets is there is a generalized decrease in calcified matrix of the bone. There is an increase in uncalcified matrix or osteoid. The white zone of uncalcified process cartilage formed at the usual site of calcifying cartilage in epiphyseal plate becomes soft bone, therefore result in deformity from the bones and the epiphyseal plate. Diagnosis of rickets must be considered in all infants with convulsions, tetany, irritability, delayed physical development, weakness, and failure to thrive. In children who begin to walk, there is severe genufalgum, genupharum, and torsional deformities, and also small stature. Suggested by clinical enlargement at the sites of epiphyseal plate, distal radius, costochondral junction. It could be established by typical radiographic changes, widened radiolucent zone in epiphyseal plate, and generalized coarse appearance of tuberculation. There is also an elevated serum alkaline phosphate level, elevated blood creatinine and serum inorganic phosphorus levels, and also there is normal blood creatinine and lowered serum inorganic phosphorus levels. Clinical aspects of the three main forms of rickets. First is the vitamin D deficiency rickets or nutritional rickets. Breastfeed and exposure to sunlight respond well to vitamin D. Early phase of vitamin D deficiency rickets is severe hypocalcemia and steatorrhea by chronic intestinal or hepatic disorders. Second is the renal osteodystrophy, relatively uncommon, formerly known as renal rickets. CKD could result in bony lesion and hyperparathyroidism. It could be treated bioactive metabolite of vitamin D. The third is the rickets caused by renal tubular defect. Underlying mechanism is the renal tubular dysfunction, which results in defective tubular reabsorption of phosphate. Therefore, there is an excess loss of phosphate in urine and result in hypophosphatemia. It is the most common type, familial hypophosphatemic rickets, or X-linked hypophosphatemia. Clinical and radiological signs of classic rickets. The treatment is the oral administration of phosphates and 1.25-dehydroxy vitamin D3. Other less common type is vitamin D dependency rickets type 1 and type 2, Fanconi syndrome, cystinosis, oculocerebral syndrome of Lowe, and it could also sometimes associated with renal tubular acidosis. The orthopedic management of deformities in rickets. First thing is to recognize the rickets. Without controlling the rickets, recurrence is inevitable. Once the rickets is controlled, bony deformities tend to regress. It can be enhanced by the use of appropriate night splints. And if severe deformities persist, we could also do an operative correction. Osteomalacia. It is a generalized disease of adult bone that results from failure of calcium salts to be deposited in the osteoid. Adult bone, there is an absence of epiphyseal plates. It's comparable to those of rickets with vitamin D deficiency, chronic renal insufficiency, and renal tubular insufficiency. Dietary type has been eradicated to a large extent by supplement of Vit D. Occur in malnourished elderly who may be exposed to sunlight less often. Pathology of osteomalacia involves generalized decrease in calcified matrix and also an increase in uncalcified matrix. Too little calcified bone result in one form of osteopenia. Microscopically, we could see what osteoid seams. Pseudo-fractures or loser's zone in Milkman syndrome. Diagnosis of osteomalacia should be considered in the presence of anorexia, weight loss, muscle weakness, and widespread progressive bony deformity of the spine and limbs. It could be established by typical radiographic changes of gross skeletal deformity and the prominence of tuberculation of bone. The serum alkaline phosphatase level is usually elevated. However, phosphate serum is lowered. Sometimes, iliac crest bone biopsy may be needed to confirm the diagnosis. Treatment. The underlying cause must be corrected insofar as is possible. In vitamin D deficiency type, administration of vitamin D and high calcium diet. For hypophosphatemic form, 1,2,5-dehydroxy vitamin D. For the residual bony deformities, correction by appropriate osteotomies. Scurvy or avitaminosis C. It is a form of generalized disease there is a failure of osteoblastic formation of bone matrix, resultant decrease in the total amount of bone, or osteoporosis, superiosteal and submucous hemorrhage, caused by a lack of vitamin C and its associated effects in the synthesis of collagen, occurs in children between the ages of 6 months and 1 year. The pathology of scurvy is the decreased osteoblastic formation of bone matrix with normal osteoclastic bone resorption that result in generalized osteoporosis. Bone matrix is not being formed on the calcified cores of cartilage in the epiphyseal plate, and there is also an avitaminosis C. Therefore, it could increase capillary fragility and result in spontaneous hemorrhage at periosteum, gums, and intestine. It could also cause epiphyseal separation. The clinical features of scurvy is undernourished child, rapid onset of irritability, swelling of the limb, and the pain that's so severe. And it's also marked swelling, warmth, and exquisite tenderness. There is also an evidence of hemorrhage in gums. The radiographic features of scurvy involve generalized rarefactions of all bones, dense white line on the metaphyseal side of the epiphyseal plate, and a similar line ringing in the epiphysis. There is also an epiphyseal separation and soft tissue shadows surrounding the long bones. Differential diagnosis of scurvy is paralysis, osteomyelitis, congenital syphilis, and child abuse. The treatment is the administration of vitamin C. Osteoporosis. Porous bone, combination of decreased osteoblastic formation of matrix and an increase in osteoclastic resorption of bone that result in the decrease in the total amount of bone. One form of osteopenia is too little bone. There is an inadequate calcification of the bone in the osteoporosis. The bone is thin, porous, but well calcified, which resulted in the normal microscopic appearance. It also increased susceptibility to fracture. Etiological factors of osteoporosis is osteogenesis imperfecta. It is a congenital type of osteoporosis, or it could also be a causative factor such as endocrine diseases, disuse, postmenopausal state, and senility. There is also genetic factors involved. Risk factors of osteoporosis is gender, amenorrhea or postmenopausal, insufficient calcium intake, eating disorders, smoking, excessive use of caffeine or alcohol, inadequate physical exercise. Osteoporosis. There is hormonal osteoporosis involving hormonal imbalance, increased secretion of anti-anabolic hormones. And there is also hyperparathyroidism, hyperpituitarism, hyperthyroidism, and also hyperadrenocorticism. Disuse osteoporosis when all tissues of the body atrophy when they are not used. Postmenopausal and senile osteoporosis. The total amount of bone must be decreased by 1/3 before it can be readily detected radiographically. There is a hypogonadism and inadequate dietary intake of calcium. Clinical diagnosis of osteoporosis is chronic and intermittent back pain, bone pain at other sites, loss of both standing and sitting height, reduction in physical performance, including respiratory function. There is also Dowager's hump or dorsal kyphosis, and also pathological fractures. For a radiographic diagnosis, general rarefactions of all bone must be prominent in cancellous bone. There is a thin cortices, deformity, and particularly in vertebral bodies. DEXA is less than -2.5. For the laboratory diagnosis, there is for postmenopausal and senile osteoporosis, we have to seek for the serum calcium, phosphorus, and alkaline phosphatase levels are normal. Treatment of osteoporosis is the prevention of further bone loss, estrogens for women only, anabolic hormones, bisphosphonates, calcitonin, vitamin D, calcium, sodium fluoride. Some degree of true osteomalacia coexists. It is correctable with vitamin D. If there is a back pain caused by microfractures, light, close-fitting brace. Hyperparathyroidism. It is rare. Combination of generalized and localized excessive osteoclastic resorption of bone with marrow fibrosis. Etiology and pathology. There is a primary hyperparathyroidism, usually from parathyroid adenoma, and it is occasionally aberrant. Excessive bone resorption. There is a liberates of both calcium and phosphorus into blood, but the phosphorus is readily excreted in urine. Therefore, there is a hypercalcemia and hypophosphatemia. For the secondary hyperparathyroidism, there is a chronic renal insufficiency, osteomalacia with intestinal malabsorption or vitamin D deficiency. The disseminated osteolytic lesions may be solid and filled with vascular fibrous tissue, hemosiderin, and giant cells brown tumor, or may be cystic and filled with old blood. Diagnosis of hyperparathyroidism involves two types of clinical manifestation. Hypercalcemia, for example in people with anorexia, lethargy, weakness, and symptoms of renal calculi, and also associated bone disease. There is a bone pain, progressive bony deformity, pathological fractures, and loosening of the teeth. For radiographic changes, there is a generalized rarefactions of all bones and disseminated osteolytic lesions of multiple bones. The earliest change involving resorption of lamina dura of the tooth sockets and cortical bones of the phalanges. For that, there is an elevated serum calcium level and also elevated urinarium calcium concentration. There is a lower serum phosphorus level and elevated urinary phosphorus concentration. There is also an elevated serum alkaline phosphatase and also elevated serum of parathyroidism hormone. Treatment of hyperparathyroidism. For primary hyperthyroidism involves parathyroidectomy. For mild cases, it could be managed medically. For secondary hyperparathyroidism, treat the underlying chronic renal insufficiency with high doses of vitamin D, or in carefully selected cases by parathyroidectomy.